Good morning, everyone. Today, I would like to talk about a new model of care which we are introducing to enhance patient care experience by improving the continuity of care they receive. This is the METS model of care which we are talking about. As some of you may be aware, our midwife managers and educators have been advocating for this model of care to be introduced in our service. We have done an evaluation of this model of care and found that this model provides a good additional model due to improved patient care. In our review, we found that this model provides a greater continuity of care for patients compared to our pre-existing high-risk models as well as low-risk models. This model allows the patient to be seen antenatally and postnatally by the same midwives instead of a different clinician in our current two models. Studies have shown that there is an increased patient satisfaction and trust when there is a greater consistency in the clinician who consults the patient during their care. This may be due to the reduced fragmentation of advice they receive. This model also allows midwives to take up greater clinical responsibility as they will be looking after both low and high risk patients, as well as having greater independence with the continual support of our staff specialists. For those of you who are unfamiliar with managing high risk patients, we do not have the expectation that you will be undertaking this responsibility overnight. There will be ongoing support and upskilling to help with the transition and improvement of clinical knowledge. From the workforce surveys conducted in the past few years, there has been consistent feedback requesting for higher clinical complexity to improve job satisfaction. We have taken this on board and believe that this is one way in fulfilling this feedback and hope that this will further improve staff satisfaction and retention. In addition to the stated benefits, there is a definite economical argument for this model of care. As we all know, the use of midwives to manage patients is a more cost-effective method compared to the use of medical doctors to perform the same tasks. As such, this model meets our hospital executives' requirements of not increasing costs with the introduction of new services to improve patient care and outcomes. We see this model as a means of increasing our outpatient consultation output to meet increasing service demands without increasing the expenditure of our department. We feel that this model provides an excellent opportunity to improve the quality of care to patients and enhance patient satisfaction, to improve staff satisfaction at the same time as improve cost efficiencies for the hospital. The next step will be the establishment of a task force to develop the best way of adopting and rolling out this new model of care in our service.